Hello, welcome to this presentation on new interRAI research published as part of the exciting Frontiers of Psychiatry special issue on the innovations in the mental health applications of interRAI assessments. My name is Keir Johnson and I work for Doctors Manitoba here in Canada, but I've been involved with interRAI instruments for about 20 years, and I'm very excited to be here today to serve as your moderator. Today's presentation will include two international mental health researchers who collaborated on a paper entitled interRAI Subjective Quality of Life Scale for Mental Health and Addiction Settings, a self-reported measure developed from a multinational study. We will begin with a presentation by Dr. Hao Luo, who is the lead author of this paper. She's an interRAI fellow and assistant professor in the Department of Social Work and Social Administration and the Department of Computer Science at the University of Hong Kong. She'll be joined on a speaker panel by Dr. John Hirdes, professor with the School of Public Health Sciences at the University of Waterloo in Canada, and chair of the interRAI Network for Mental Health. As well, joining us today is Dr. Alice Hirdes from the Graduate Program in Health Promotion, Human Development, and Society at the Lutheran University of Brazil in Porto Alegre, Brazil. We will provide a web link to the articles in the special issue at the end of today's webinar, and you'll find the links in the YouTube description. Hao, I'd like to invite you to begin your presentation.
Hello, everyone. I'm very happy to have this opportunity to talk about our very recent work on developing interRAI quality of life scale for mental health and addiction settings. As you can see, this is a collaboration work of many interRAI fellows from all corners of the world. So first, very briefly talk about why do we care about quality of life. The recent decade, there has been a major shift in mental health service policy. So there has been a change from an emphasis on symptom reduction to a more holistic approach, which we consider the recovery, social functioning, and quality of life are very important component. So there is a growing consensus that perspectives of mental health service users should be highly valued in evaluating clinical trials, surveys, and policies. So this leads to a growing amount of research in trying to identify a very good patient report measure of quality of life in mental health practice. And why do we need an interRAI quality of life measure? We agree that there have been several instruments available, and there has been a review study looking at measures on quality of life for people with severe mental illness. But still, up until now, the most commonly used one are generic measures such as EQ5D and SF6D. But there's a problem that current evidence suggests that these generic measures may not fit for the purpose in mental health, as they displayed a low level of sensitivity and relationship with mental health condition-specific indicators. So this brings to our study. We want to develop and validate a self-reported quality of life scales for inpatient and community mental health setting that are just specific to this population. And the method we took, we applied this interRAI self-reported quality of life surveys to a total of 2,218 participants. And we have our trained interviewers from Canada, Belgium, Finland, Russia, Brazil, and Hong Kong from 6 jurisdictions, and during a period between 2010 and 2020. And in this survey, 37 items have been used to develop this quality of life scale. And we have participants from different settings, from community and mental health setting, inpatient, transitional care, and also 30% are from the general community. And we administrated staff measures only to persons who are currently using mental health service. So the analytical approach, a little bit technical, we have split the data into a training set and a test set. 70% are training samples, 30% a test. And using the training data, we're trying to get a general sense about what might be a plausible structure of our scale. So we want to determine the number of factors there, how many dimensions, and what might be the items that measuring this dimension. And then we went further to base on this EFA result to use a confirmatory factor analysis approach to see to what extent our data agree with this factor structure. And then we also tested in our testing data, which are not involved in generating the plausible structure. And we followed quite detailed protocol. This is our final result, a confirmatory factor analysis result for both the training sample and the testing sample. As you can see in the end, we find 4 dimensions. The first one is well-being and hope, measured by 8 items. For example, there are questions about whether the person is hopeful about future, whether their life is getting better, do they feel good about themselves? And then we also have 7 items measuring the psychosocial dimensions to see whether the person has good relationship with their family and friends. So these are 7 items. And then we have 5 items measuring support. So for example, if the person can get health service when needed and can get support for making decisions. And then 3 items measuring whether the person has been participating in meaningful activities. And in general, the reliability of the scale is very good. It's 0.92, very high. And our data fits the model very well. All the model fit indicators suggest that this is really good model. And even if you look at reliability of the subdomain, even for this small domain with only 3 items, we still reach acceptable reliability of 0.72. So this is about the quality of life scale. And then we also have result of our staff measure, which is an 8-item, 1-dimension measure, measuring whether the person have a good relationship with the staff and whether their privacy has been well respected. Also, the model achieved fairly good fit. So here is the conclusion. So the SQL MHA scale is a concise 23-item scale measuring 4 domains, as you can see here: well-being and hope, relationships, supports, and activity. The total score ranged between 0 and 46. And these 4 domains share very similar aspects in key process of recovery, such as hope, self-determination, connectedness, and meaningful activity. So we believe that these subscales and also these 8-item staff relationships can be used to assess specific domains of quality of life of interest and to identify areas of improvement that should be targeted on. So this is my very brief presentation about our work. Thank you.
Thank you very much for that presentation, Hal. Very interesting work, and I know a lot of viewers would like us to delve a little deeper into this. I noticed that the study includes data from a number of different mental health care settings in a number of different countries. Can you tell me why it's important to use international data to develop a scale like this for quality of life?
Well, I think whenever you're applying a scale in your specific context, we always concern whether the scale will work exactly the same in this specific context, especially when the scale was developed from another population, a country, a region with very relatively homogeneous cultural background that you think is very different from your own situation. And we worry about the language, interpretation, the culture, and how people express themselves. So this kind of study involves diverse service setting, inpatient, community health, and general setting, and also from actually 6 jurisdictions. We do this just to ensure the generalizability of the scale. So to what extent this can be used to all different kinds of population. And I say we cannot say that we have eliminated bias caused by so-called sample-specific characteristic, but I think to a large extent, this is one of we have made quite an effort to ensure the external validity by using multinational data.
Thank you for that. Now, I have a small confession to make. I've followed most of the presentation, but I'll admit that statistics is not my forte, and I suspect there may be a few people watching who were with me. So I wonder if you could explain the statistical approach you used for this analysis in a way that I might understand or a lay audience would understand.
Well, Well, this is very challenging. So yeah, I agree. I teach statistics. It's difficult. The method we use, I would say, is actually a very standard approach for scale development. So whenever we care about the reliability and validity of the scale, we do this kind of analysis. So first, we did something called exploratory factor analysis. You can judge from the name, we're trying to explore. So this is more a data-driven approach to just let the data tell us some story. We're basically only working at the correlation between items. So what items are performing sort of similarly in this population, and then we tie them together. So first, we use a very data-driven approach to uncover the underlying structure. And then, okay, they suggest us some kind of structure, and we, for example, how many dimensions are there? What are the items that are measuring this latent construct? And then based on this result, we come up with a hypothesis model. It's a theoretical model that we think these items are uniquely measuring one domain. And then we use a more confirmatory approach called confirmatory factor analysis to test to what extent our data actually agree with this model. And then I think something we did additionally is we split the data sort of from a machine learning perspective. And first we find a model, and then we test the model from an external set. So we saved the 30% of the sample untouched, and then only to test it based on what we generated from the 70%. And then also shows that, okay, it works pretty well. So the scale should generalize very safely to another population.
Well, thank you for that.
I hope it helps.
It definitely helped, and I think my life would have been a little different if I had you for intro to statistics a few years ago, more than a few years ago. So one last question for you, Hao. This is obviously very important research, and quality of life is such an important aspect of recovery in mental health and addictions. And I wonder how confident you are that we could use these measures in future research on quality of life in the mental health and addictions world.
I think, as we said from the very beginning, the person's perspective is very important. So we definitely need to take that into account. That was interRAI is trying to add from the amount of great work we have already done. And talking about this scale, I mean, I think I'm more comfortable to comment from a methodology perspective because I'm a methodologist. Actually, the work has been ongoing for quite a while. I think 3-4 years. Or 2-3 years. In the very beginning, when we don't have sufficient number of samples, we already start to explore the data. And I think we started to fit model when we have a sample size of 1,500. And we find some data structure, and we already have a scale in mind. And then we're not so sure. We want more data to make sure that we had a very robust result, and actually find that, you know, as more data coming in, our result has been very stable. There's not so much change. Sample size are relatively small. I would want to go deeper to have bigger sample size from all different kinds of places. And there are much more interesting research to be done. But I think at this stage, I'm very confident to say that we got very robust results from this sample, and it will be a very valid scale that can be used for measuring quality of life in mental health and addiction. Yeah.
Thank you for that. I'd like to bring in John Hirdes to the discussion. Of course, he's the chair of the interRAI Network on Mental Health. And John, we've just heard some of Hao's perspectives on this quality of life scale, and I'd like to get yours. Is the quality of life survey for mental health and addictions different from those other assessments? How is it different, I should say?
Yeah, thanks, Keir. The quality of life surveys actually fill a very important, unique role and sort of fill in a gap for us in the interRAI family of assessment instruments. So the first thing I would say is that all interRAI assessments deal with quality of life, but they deal with it from different perspectives. Quality of life is a complex concept that has many facets to it, many different dimensions to it. So the instruments like the interRAI mental health, community mental health, the emergency screener for psychiatry, all assess quality of life and other aspects of life like clinical symptoms and medical concerns from the clinician's perspective. The clinician interviews the person, observes the person, looks at the chart, speaks to family members, speaks to other clinicians on the team to make the clinician's judgment about what the answer is for whether the person is showing signs of depression or pain or poverty or social isolation. The quality of life surveys add the person's perspective, that subjective dimension of quality of life that only the person knows about, and it expands the focus on broader psychosocial issues than can be covered from a clinician instrument. So they're very complementary and fill an important role in broadening the spectrum of issues related to quality of life covered by the interRAI instruments.
Thanks for that. And, I'm thinking back, about 20 years ago now to my first introduction to interRAI, which was with the home care tool. And there were a lot of clinicians who were reluctant to embrace new measures. The cognitive performance scale, no thank you, I want to stick with the mini mental. And one of the things that I found helped them make the transition and see the advantage and actually the pros to the interRAI scales was understanding the research behind it, the rigor that went into that. So I wonder, could you tell me a bit about how interRAI did the research to create this survey instrument?
Yeah, it was actually about a decade's worth of work if we were to go back to the origins of it. So where we began was a broad-based literature review to see what's being done in the literature around quality of life, psychosocial well-being, life satisfaction, patient experience, all that literature in mental health and in other sectors of the health system. But then we did a particular deep dive in the literature on recovery, because recovery is such a critical concept in mental health services. And what we wanted to focus on was those subjective dimensions of recovery that we really couldn't address in the clinician rated tool, but that we could get the person's experience. So we looked to see what were the best and most powerful domains that we could find from that literature to test those. And then we sought out international sites and diverse settings to try it out. So we tried community mental health agencies and inpatient settings. We wanted high resource nations, but also low and middle income nations. We wanted cultural diversity in there to see did it work in as many settings as possible. But the other part that was important is we also wanted to test this in the general population. Because if I want to understand an item like I'm hopeful about the future, I need to know what does a person who's experiencing mental illness feel with respect to that item, and how does that compare with the average person in the population? Because we needed that general population reference standard to really understand the distributions in persons with mental health concerns.
Well, that makes a lot of sense to me, and knowing there's a decade's worth of research behind this certainly should be something that gives people a lot of confidence about this scale. Or this survey, pardon me. One last question for you, John. I'm wondering how this survey measure, how does it measure the same thing as health-related quality of life measures that are often used by, let's say, health economists?
Yeah, so in the health economics literature, there's often a reference to health-related quality of life. You'll hear demographers talk about quality-adjusted life years. Those measures actually deal with something quite different from what we dealt with. They're really symptom-based measures with a focus on really one mental health symptom, distressed mood, and then a series of physical disability and physical health symptoms. That's not what our quality of life survey is about. Our clinician-rated instruments deal with psychiatric symptoms, physical health symptoms, those broad clinical dimensions. Our quality of life survey really focuses on the person's experience, their sense of belonging to a community, having meaningful things to do in their lives, having relationships that they can count on, feeling hopeful about their future. All those major psychosocial concepts that come out of the recovery literature aren't addressed at all by health-related quality of life measures, which are more symptom-based measures, whereas ours is about the psychosocial experience.
That's great. I'd like to bring in our third panelist to this discussion, Dr. Hirdes, joining us from Brazil. And I wonder if you could describe for everybody watching the mental health agencies from Brazil that actually participated in this study. What kinds of services do they provide, and what kinds of challenges do they face?
Hello, Peter, John, how? It's nice to be here with you. Data was collected in 4 psychosocial care centers here in Brazil, 3 of them in Rio Grande do Sul state, in my region, in my state, and one of the Rondônia state in the north part of Brazil. The psychosocial care centers provided treatment to people with mental disorders and to alcohol and other drug users. Here in Brazil, we have 3 types of psychosocial care centers, named CAPS, to adults, to child and adolescents, and to alcohol and drug users. And additional data was collected in primary health care with patients, participants in therapeutic groups in Rio Grande do Sul state.
Thanks for the overview. I'm wondering your perspective, Elise, on how feasible it is for a low resource nation to use the quality of life survey in mental health and addictions programming.
I think this is an easy instrument to use, an easy survey to use in low and middle income countries because the instrument is not too big. The questions are really clear. And this is easy to make the translation, back translation, and all the process involved in using an instrument or adapting an instrument to a different culture. This is important to say that probably in low and middle income countries, we need to use 2 versions of the software, a version offline and another version offline, because in low and middle income countries, sometimes there is only one computer to all the team in a psychosocial care center. Yeah? And in very regions, far regions and in rural regions, the internet is not good. And I think it's important to say that this instrument is really important to use in community mental health centers, like the psychosocial care centers here in Brazil, and to use in primary health care, because some of the items and some of the domains reported to the territory. This is a very strong point of this instrument too. And the good results of the Brazilian data shows that the most important is not the resources available to the psychosocial care centers, but the technologies. We name it here in Brazil the light or the soft technologies. It means the relationship with the patients. This is the more important, because this government reduced the investments in the new psychosocial care centers here in Brazil now.
Thank you very much for that, Elise. One last question for you. Why is it important to measure the patient or the person's perspective when evaluating mental health and addiction services?
The person's perspective is important because it can show the domains that need more attention and the strong points. And here in Brazil, the good results of the first survey improved investment in psychosocial care center. They moved it from a very small, a very poor physical structure to a better structure downtown. It means, in other words, research and practice changing realities and lives.
I wonder if I could ask our other panelists that same question. John, if you want to weigh in about why it's important to get the patient or the person's perspective.
Yeah, so if you want to understand the person's experience, really, the person's the only one who can fully answer that. And one of the things that's interesting in the quality of life literature is that people that are in the same objective context have different experiences when it comes to their subjective evaluation of quality of life. So you can have a person in a high resource setting with lots of economic resources and wealth, and somebody who's living in poverty, but they may not have the same perspective. The person who's wealthy may not be happy with their lives. The person who's dealing with poverty may have found ways to cope with it, may have hope about the future, and may evaluate their context differently. So we can't assume that we know everything about the person's life if we look only from that external perspective. We need to see from their point of view, what are they experiencing?
Great. And how, anything to add to that?
I think I just want to echo John. I think it's just because of heterogeneity. I mean, even for people with exactly the same clinical situation, and you still find they have different quality of life. And then what we really need to do is to find what are the additional things that we can do to make people feel better about their life. Yeah, so that is why I think it's adding a very, very important component to the big family of interRAI instrument.
Great. And a couple of questions for the panel while I have you. What's the next step for the research that should be done in this area?
Well, maybe I'll start with that in terms of what our next plans are. We'd certainly like to expand the coverage of the countries that we tried this out in to get even more cultural diversity, more differences in experiences that we may see around the world in mental health settings. And Hal can talk on what needs to be done to get more sample representativeness in the future, perhaps. But I'd like to start to see us do longitudinal research to see how do people change over time. So if we were to sort of think about somebody who's struggling with different aspects of their quality of life today, and then they receive a recovery-oriented intervention in mental health services, does that translate to better quality of life outcomes? I think that's an important next step for us to move to in the research.
So going broader and longitudinal, essentially. I wonder if Alice or Hal, if you have anything to add about the next steps for this research.
I think here in Brazil, it's important to use this survey in another agencies, in another psychosocial care centers, in other states, because we are living in a continental country. The realities here are different. In this way, we cannot say that this data represents all the country. This data represents part of the psychosocial care centers, and not all the country. But at the end, I think it's very important to evaluate and to measure quality of life of people with mental disorders, because at the end, we can see the quality of care the psychosocial centers deliver to the patients and their families.
Thank you. Hal, anything to add?
I think just one point that, of course, I totally want it's going longitudinal and going to different countries. I think another point is, since interRAI already have vast amount of clinician-rated assessment, so I think the important first step to link it with what we already have, and then we can find a lot of what are the factors really associated with quality of life, just making use of the existing data we currently already have, and just add on that.
Thanks. I'd like to close with one final question. And I'll preface it by saying this. One of the things that I've always loved and admired about interRAI is how the academic, the research community involved with interRAI is ultimately there trying to support the front line, trying to support the delivery of services, the professionals delivering those services, and ultimately the patients or the people receiving those services. So in that spirit, I'd like to ask you, what do you see, each of you, the practical applications for the interRAI Quality of Life Survey for mental health and addictions?
Sure, I'll give one to add to that mix, and that's around program evaluation, that this becomes a new dimension that we can evaluate the effectiveness of services around, because it gives that softer, more subjective aspect of an outcome related to mental health services that we can measure, in addition to the clinical response in terms of symptom sets that are of interest. We can also look at the broader person's experience, and we can evaluate these outcomes between programs or when new interventions are introduced to the mix. And the other thing probably I'll just throw in here to mention is there's a second paper in the Frontiers special issue on a subjective quality of life measure for children, and we'll be picking that up in a future interview series.
That's great. Elise, do you have anything to add?
I think I told this before, but this survey is really important to change, probably to the government, maybe the new government, put some resources and community mental health services like psychosocial care centers instead of psychiatry hospitals like they are doing this now.
Thank you. And how? Anything to add?
Yeah, and just thinking about local context, I know that Hong Kong is trying to just upscale our usage of community mental health. So I think for add on that, we should really add the quality of life instrument in any of the current work that implementing interRAI instrument. Our quality of life is really one of the worst. It's so much lower, even for people with similar situation. So yeah, I think it's really important for Hong Kong specific research to understand why our people with mental health conditions have really low quality of life. Yeah.
Thank you for the last word there as the lead researcher on this. I'd like to thank our panel today. That includes Dr. Hao Luo from Hong Kong, Dr. Elise Hirdes from Brazil, and Dr. John Hirdes from Canada for your very important work in this area. We look forward to future developments in this important research. I think mental health and addictions are issues that are confronting countries all around the world, and everybody is trying to do better in this domain. I'd like to thank everybody for watching this presentation on interRAI's research in mental health and addictions. It is part of a series. And if you would like more information about this or related work, I'd invite you to contact interRAI by emailing info@interrai.org. That's info@interrai.org. Thank you very much.
To see all the articles in this special issue of Frontiers of Psychiatry, please visit the website shown here, or click on the link posted below this video. Visit the interRAI website at www.interrai.org at any time to view the new presentations on this special issue as they are posted.